I could tell you with great confidence that my Medicare patients could care less how much the federal government spends on health care. But they do care deeply about the amount they have to pay out of pocket to get the care they need. With rare exception, MA plans implement cost sharing in a one-size-fits-all way, in that each beneficiary is charged the same amount for every doctor visit, every diagnostic test, and prescription drug. People ask me all the time whether the amount of cost sharing faced by MA members is too high or too low. The answer, as every clinician knows, is it depends. But asking MA members to pay more for all services, despite clear differences in clinical value, results in decreases in the use of essential care, the care I beg my patients to do. And this cost-related non-adherence negatively impacts our most vulnerable patient populations. So I see this blunt one-size-fits-all approach as penny-wise and pound-foolish. Does it make sense to you, Mr. Chairman, that my MA patients pay the same co-payment to see a cardiologist after a heart attack as to see a dermatologist for mild acne, or pay the same prescription drug co-payment for a life-saving drug that treats diabetes, cancer, or depression as one that makes toenail fungus go away? Realizing that MA beneficiaries use too little high-value care and too much low-value care, I endorse a clinically nuanced cost-sharing approach as a potential solution. Clinically nuanced value-based insurance designs set consumer cost-sharing levels to encourage the use of high-value services and providers and discourage the use of low-value care. For the record, I support high cost-sharing levels, but only for those services that do not make MA beneficiaries any healthier. Led by the private sector, VBID is implemented by hundreds of public and private employers, several states, and will soon be incorporated into the TRICARE program. The integration of VBID into MA has garnered broad multi-stakeholder and rare bipartisan support. I would like to acknowledge subcommittee members Diane Black and Earl Blumenauer, whose bipartisan leadership on this issue led to the 2015 announcement of the MA VBID model test, a 5-year program that allows designated plans, now in 7 states, to reduce cost sharing for specific services and providers, but only for those beneficiaries with specified chronic conditions. In January of this year, 9 MA plans successfully launched disease-specific programs combined with enhanced benefits to help people manage their chronic diseases. Responding to interest from MA plans in other states, CMS added 3 more states to the demo starting next year. So due to the VBID success in the private sector, the TRICARE pilot, and nationwide interest in the MA VBID model test, bicameral, bipartisan legislation has recently been introduced to allow MA plans in all 50 states the flexibility to allow MA plans to set beneficiary cost-sharing levels on clinical value, not price, of medical services. It is my hope that the subcommittee supports the national expansion of VBID and MA, which when coupled with other promising integrated models like the PACE program discussed today, could result in healthier Medicare population, which motivates me as a physician, and more efficient federal expenditures, thus serving the best interests of American taxpayers and future beneficiaries. So it's my great pleasure to support the Medicare program, and I'm happy to work with the subcommittee further and look forward to hearing your comments and answering your questions. Thank you.
Thank you, Doc. Not bad for a Michigan guy.
Thank you.
Doc, you mentioned the CMS VBID demonstration, and in your opinion, if you could expand on, is that the demonstration is set up in a way that allows Medicare Advantage plans that the necessary flexibility for them to reach the full benefit of the VBIDs?
So that's a great question, and it's important to point out that, as mentioned in Dr. Jacobson's remarks, is that when Medicare was introduced in 1965, one of the foundations was this non-discrimination clause that every American in Medicare have the same benefit design. And as all clinicians and like Representative Black know, that medicine is unbelievably personalized and moving rapidly in that direction down to the level of the gene. So we have argued that people should be treated differently and given access to different care, most notably an eye exam, which should be more easily assessed by someone with diabetes than someone who doesn't. And it was quite a task, and I thank the subcommittee for the leadership to have this waiver be the first ever to allow a Medicare recipient with a specific condition to have a different benefit design than someone else, allowing precision medicine to be aligned with benefit design. So important step forward. 3 of the states that are expanding to next year are represented on this committee, and I think that there is movement afoot by CMMI to allow greater flexibility and uptake of these programs. Most notably, one is that the conditions are designated by CMMI. I think the plan should have a little bit more flexibility to decide which population should be available to have greater access to certain services and providers. I think that we should allow the plans to expand the services that they can reduce cost sharing for across the entire spectrum of care. And I think given that the fiscal responsibility that we must attend to with any changes in Medicare is, say, we can't always spend more and we often have to cut back. And given that most of the blunt instruments get people to use less of all care, I think it's important now for Medicare to walk very slowly and carefully into the area of reducing the hundreds of billions of dollars of Medicare expenditures that don't make one beneficiary any healthier. There is a new initiative called the Choosing Wisely program, which has launched over 40 clinical specialty societies naming specific services that maybe we're doing too often and spending too much money on. So broader spectrum of services, more flexibility on the specific conditions, and start to pay attention to the fact that while the best part of the demo is making high-value services more accessible, to be fiscally responsible, we have to start thinking about clinically driven reduction of low-value care.
Thank you.
Thank you, Mr. Chairman. Admonition received. June is Alzheimer's and Brain Awareness Month, and it's no surprise to anybody on this panel the devastating nature of this disease. 6th leading killer in the U.S., 5 million Americans are suffering from it, and some folks suggest that it's the most expensive disease in the United States that people are suffering with. One of our colleagues, Representative Sanchez, and I have been working on legislation that would authorize a CMS demonstration in terms of a general approach on this. So that's all to say there's a lot of interest in how all these things have an interaction with Alzheimer's in particular. Dr. Jacobson, what's your insight or what's your perspective on how many Alzheimer's patients are enrolled in SNPs, and in your opinion, what are the benefits that these plans have for Alzheimer's patients and their families based on your experience? Dr. Fendrick?
Briefly, just for the reasons that you state, Mr. Roscom, I was very pleased to see that not only were 3 states added to the VBID demo for 2018, but 2 conditions were added as well, which dementia was one. So we're very hopeful, since many of the states represented on this subcommittee are actually in those demo states, that the 7 original states in Michigan, Alabama, and Texas, all represented here, would talk to their Medicare Advantage plans to encourage them to step away from diabetes, heart disease, COPD, the more common conditions now in the current demo, and think outside the box and move to explore a VBID MA dementia model that would, I think, lead to the increases in care that you're looking for.
Okay. Thank you all. Thanks, Mr. Chairman. I yield back.
Thank you. Thank you to our witnesses here today, and certainly I appreciate the perspective. My colleague just raised some concerns about rural areas and perhaps the flexibility. I know that flexibility in general has afforded a lot of Americans within Medicare Advantage some options, and I think that is helpful, but it certainly hasn't really provided as many options for what I would say rural residents and then residents of very remote areas. And sometimes those services just are hard to come by, and whether it's Selma or whether it's ranch country in rural Nebraska, that there are some vast areas there that I hear, from various seniors, their concerns. But I'm just wondering if you would like to elaborate at all on what was already asked, or what other innovative ideas you might have, Mr. Grabowski, or Doctor, I guess it is, if you would care to elaborate.
And I think your question brings up this point about extending healthcare coverage to a broader segment of healthcare services. As you can see in my testimony, the VBID MA demo model focuses on high-value services, high-value providers, but we worked very, very hard to include expansion of supplemental benefits. So I see patients like Miss Eva every week, and if for some reason we figure out a way to get her medications or get her specialty visits, but she has no way to have transportation to them, the whole thing falls apart. So one of the more interesting aspects as we hope the MA demo goes nationally, that instead of maybe saying that you should go to this hospital or use this medication, that maybe the demos will focus on these supplemental benefits like transportation and other types of services that may not be considered in the sweet spot of the realm of typical insurance designs.
Sure, thank you. Because I think there are a lot of great stories to tell about overall access and affordability within a fiscally responsible way. It's just that there are still some gaps out there.
Thank you, Mr. Chairman. I appreciate our having this conversation. Dr. Fendrick, appreciate having you back. I am continue to be quite enthusiastic about the simple logic that you described, some of the work that's underway. I appreciate you giving us some specifics that you think might make a difference to accelerate the progress. And Mr. Chairman, I would hope that this would be an area that we could spend a little more time. As you know, Congresswoman Black and I have had legislation the last couple sessions. We're fans. We think that this can be advanced outside the scope of some of the things that get us tripped up around here. And I think there's some really powerful evidence that we can help provide better care and bend the cost curve. But there's just one area, Doctor, that I would seek your advice and counsel, because there are questions about the applicability for VBID in very low income populations who aren't involved with a co-payment, can't afford more, or some of them have no cost sharing. Do you think that there are ways that this can be applied in value-based design to be able to get around this, to be able to provide the power of the concept for people who don't have that type of co-payment or capacity to pay more?
So first off, thank you for the kind words. It's happy to be back, and it's a great pleasure to be talking about one of the rare bipartisan healthcare reform ideas. And I appreciate your work and Representative Blacks and others on the committee to make this happen. So we have studied the impact of increases in cost sharing, because that's what's largely happened in this country, and it comes as no surprise, and you don't need advanced degrees like my fellow panelists to know that if you make people pay more for something, they'll buy less of it, and poor people are impacted by higher prices than rich people are. So we have focused very, very much on those people with multiple chronic conditions and those who are economically vulnerable, and have basically tried to implore public and private payers, if you can't extend VBID principles to everyone, you should probably extend VBID principles and lower cost sharing to the people who would benefit the most, and those are the sickest individuals and those who do not have economic resources. The good news is we heard, such as the PACE program, there's been already integration of VBID principles to make sure that those who cannot afford essential services can. That doesn't mean it's happening all over the nation. I think it's particularly germane regarding prescription drugs in this program, and we have focused a lot of our attention on trying to extend this clinically nuanced cost-sharing issue to the issue of Part D drugs. We know that there are a lot of low-income Medicare beneficiaries who are either cutting their pills or taking them every other day, or not taking them as their doctor or nurse practitioner prescribed the way they do that. And there has been external influences like patient assistance programs and charity programs to help bridge that gap. It is our hope that if value-based insurance designs are put in place, whether it be for middle income or low income, that those services that are deemed to be highest value would have zero cost sharing, regardless of income, which is the case for many preventive services in Medicare now, much of the credit from this committee. And we are hopeful that as VBID ideas are extended, particularly for those extraordinarily well-established high-value services. To Dr. Gretchen Jacobson's point is, I don't want to get into the areas where there's controversy when there are 20 years of evidence of quality metrics in the Medicare program. Let's start with those low-lying fruits. And if we can't extend them because of fiscal issues to every Medicare beneficiary, then obviously the best place to get a return on investment would be to focus those on the populations who are most likely to achieve benefit, and those are the low-income folks.
Well, I'm hopeful that we won't ignore the areas of controversy, but I subscribe wholeheartedly to the notion, let's start where we can, establish the principles, spread the benefit. Right. But having a sense of how we can develop the nuance for the lower income, where there might be some way of having a more powerful incentive, or some of the nuance through the program administration, if you could lend some thought
I'll just quickly say that not being a legislator or a lawyer, not understanding all the regulations. In the commercial sector, where the VBID experience is much better studied and wider implementation, there are public and private employers that are extending greater subsidies to employees who are, say, hourly compared to salary.
Yeah.
There is
I understand. I just would like your reflection at some point about where there is no cost share, very low income, how we can refine perhaps that incentive. Mr. Chairman, thank you. I appreciate the conversation, and I hope that we can dig a little deeper here. This is very helpful.
Thank you. Me too. The gentleman for Wisconsin. Mr. Khan is recognized for 5 minutes.
Thank you, Mr. Chairman. I want to thank our panelists for your testimony here today. I represent a very large rural western Wisconsin district, and we're kind of proud in Wisconsin for some of the unique pilot SNP programs that we have, especially with the dual eligibles back home. We've got about 26% penetration with MA plans. Those numbers have been going up, even in the large rural area. And I'm a big believer in trying to move the system to a more value, more quality, more outcome-based incentive system, whether it's through delivery system reform or payment reform. And Dr. Fendrick, with the value-based insurance plans out there, just how much more can we be pushing? How quickly, and when can we start bringing this really to capacity so that we start seeing better results at a better price?
Yeah. So I think I appreciate that comment. I think a lot of people were talking about alignment in a different context earlier in the panel. I want to talk about alignment to you as I know you've been pushing for value and caring more about health than cost, even though we have to be fiscally responsible and clinically nuanced at the same time. Most of the major reforms going on in American healthcare, and particularly in Medicare, are these supply side or provider-facing initiatives trying to get clinicians like myself to behave different and better. And I think we've made marginal success in this regard, moving in that direction. We have not done the same for the patient-focused side. We have continued into this kind of one-size-fits-all design. And I think for me, to think the end-all is to find a situation where clinicians, hospitals, SNPs, ACOs, whatever, are aligned completely with the patient. That imagine now, Mr. Kind, I am paid a bonus to get my patients with diabetes to the eye doctor.
Right.
And my patients are in a plan for which they can't afford the deductible to go to the eye doctor for that exam. So my view about alignment is not more these granular issues. Imagine a situation which we are moving slowly in a bipartisan way toward, where both the providers and the patients are aligned over health, understanding that we have to be fiscally responsible in this regard.
Well, we've got, numerous alternative payment methods out there, different pilots. I think one of the best things we created in the Affordable Care Act was a center on innovation, so we can start experimenting in these areas. But is there more? Is there another pilot or something that you envision that's a center on innovation ought to be setting up and working with in order to move down this path?
Well, I'll stay with the chairman's theme of integration. I think that one is not so much creating new pilots, but getting pilots to think about one another. And since many of you are from rural areas, one of my favorite demos is the Pennsylvania Rural Health Model, which has been taken in a bipartisan way in that state. Again, many rural districts there to try to preserve and protect access to care for many of those individuals who live in those areas, but being fiscally responsible in that way. And this is largely at this early stage a way to deal with hospitals and clinicians there. And they're only just now thinking about how to better engage patients to get care locally when it's best for them, in that rare instance where they have to go to a center of excellence to go elsewhere.
Yeah.
But I want, again, many of these conversations are driven by dollars. And I love your theme of the fact that we have to think about health as well as dollars in moving these ideas.
Mr. Grabowski.
Thank you, Mr. Chairman. And I want to thank you, frankly, for holding this hearing, which I think is really focused on something which is so important, which is this effort to assure that we continue to look for innovative ways to deliver quality care while at the same time looking for ways to hold down costs. And I am moved by a couple of realities. One, the recognition that when we get to the Medicare Advantage population, we've got about 50% that consume about 3% of the costs, and then a very small percentage, 10%, that account for about the other 2/3. So we know we're dealing with a very targeted population to begin with. And what I found actually sort of heartwarming and is sort of counterintuitive. You would think that Medicare Advantage, it sort of falls disproportionately, that the wealthier you are, the more likely you are to purchase the plans. And yet, to the extent that I've been able to look at it in my own district, they have been, people who have taken the time to invest in getting these plans, and not always people of the highest means. So there's an effort on the part of those who want to be consumers of it. But Dr. Fendrick, I want to focus on what your testimony was earlier about this being directed towards the patient, not just specifically the payer. One of the things that we are looking at is legislation that would create more flexibility to prevent chronic illness or improve care coordination, the kinds of things. How do will you speak to that issue of flexibility that you'd like to be able to see so we can deliver to this chronic group and really not just cost savings, but it is quality. It's these people are better off.
Right. So excellent points. So first off, healthcare is very complicated. Who knew, right? So it's been a long-standing fact that a significantly small portion of populations in Medicare and commercial, right, they expend a very, very large part of the healthcare pie. Most of the fabulous innovation that's going on that allows me to better treat these patients, and I congratulate Congress for the bipartisan passage of the 20th Century Cures Act, which allows even a greater influx of innovative funds to allow me to take care of my patients better. So that's all well and good for those of us who are trained to improve the quality and length of life. Almost all of these innovations, with very few exceptions, come at a significant expense, which requires that tension that I prefer you to have than I do, which is we want to do the best for our patients, but we also have to be fiscally responsible, which you mentioned very clearly in the call of this hearing. So as the practice of medicine moves forward at a rapid pace, Star Wars, we have precision medicine, we have genetic medicine. The delivery system, in my opinion, is like the Flintstones, right? So the delivery system has not been able to catch up to the incredible science that we've had. So we have one of two choices. One is that we slow down the innovation in the Star Wars medicine, which I would not advise, or we continue to have conversations like we're having today and have experts like I have to my right to think about ideas that allow us to have the delivery system catch up to the precise example that you raise. And again, going back to 1965, there was this important issue to make sure that every Medicare beneficiary had the same benefit design. I would argue, 2017 and beyond, given that we can't give all things to all patients, that instead of blunt instruments, a much better approach would be one that's individualized, similar to the situation that we heard in the PACE programs.
Actually, this is part of the legislation is to create supplemental benefits for those that are chronically ill, sort of to address that. You think that would go towards the objective that you're articulating?
Absolutely, and again, it's baby steps, but the initial VBID MA demo not just includes Services and Providers, CMMI, was very, very careful to follow advice from this committee to allow the demo plans to extend supplemental benefits as part of the demonstration package. So a broader view.
Thank you for your testimony. Mr. Chairman, I yield back in light
Thank
of the
you.
time.
Mr. Reed,
Well,
recognized.
thank you, Mr. Chairman. I was just going to listen today, but Dr. Fendrick, you touched on something, and I want to follow up on my colleague from Pennsylvania on it, looking at it from a beneficiary-patient perspective. So one of the things I firmly believe is that people react to their own fiscal condition. If they see money in their pocket, it seems to generate more behavioral change, in my opinion, than other items in this arena. And so, are you aware of any studies that talk about human behavior and the impact that having a carrot approach to this may have a beneficial income on a reimbursement model? You're talking about, in some of your testimony, for example, the diabetics and having foot and eye exams with no co-pays, that type of thing. Yeah, that's a bottom line financial impact to an individual, but do they really see it? And what I mean by that, I'll tell you a story. When I was a kid, I was raised by a single mom, youngest of 12, and every time we went to the bank to pay the bills each month, she would cash her checks to hold the cash and then give it back. Any type of creative, innovative ways that we could talk about in regards to reimbursing patients for seeing and follow-up care, medication adherence? You get kind of I've even had talks with CEOs of different carriers about even giving them a gift certificate for doing that. And they told me that regulations in New York prevented them from doing that, or maybe they're federal regulations. Does that carry any weight, that kind of nominal type of impact on human behavior? Do you think that could change the curve?
So I should bestow a degree of behavioral economics for that. I mean, David and others are experts here on that. So,
Well, let's go to David too after you, but
so
please,
first
from your
off,
patient
the
perspective.
Kaiser Family Foundation has all this information, a lot of good information in the testimony and elsewhere to answer these types of points. I do believe strongly that particularly in the low-income folks that we talked about earlier, that something as low as $1 matters. So I have seen Medicare Advantage patients who are faced with $4 copays for drugs that everyone in the exam room knows will be meaningful changes, but you never want to be in the situation to either pay rent, buy food, or fill your prescription, which is why we argue for these types of things. But I want to make sure, since it's not all things for everyone. I would like to start with those conditions and those services for which there is no doubt that they should be prescribed and used in those situations, which is where the nuance comes in. In some commercial settings, we have gone beyond free, and we have actually paid people to do certain things like quit smoking or take their prenatal vitamins or other types of things.
And we've seen a positive change.
We do, but
Right.
we also have what I call the frozen carrot, that if people are given an advantage in lower cost sharing to do certain things and they don't, they should also be accountable for that
They
behavior
get the
as well.
stick on that side.
So I call it a frozen carrot. I'd rather call it that.
A frozen carrot, very good. David, could you offer on that?
Yeah, absolutely. And you come to Congress and a behavioral economics lecture breaks out here. This is great. As Mark described, I really like these programs. There's been a lot of positive studies. I'm thinking of the work of Kevin Volpe at the University of Pennsylvania, where he's kind of paid patients to take particularly high-value drugs, and it's VBID on steroids, basically, and it's been shown to be very effective in those applications. So I think you raise a really good point, Mark, that accountability is key in these kinds of programs as well. But I do think if there's going to be huge costs to the healthcare system of non-drug adherence here, we want to make certain that we're potentially incentivizing individuals to adhere to their drug.
And would you agree, David, that even $1 would matter to a lot of those individuals, change their behavior to adhere to their medication?
It absolutely does.
You know it does.
I want to say one thing that you may find very interesting as the argument breaks out here. In a large commercial experiment, we offered Americans in really good insurance plans who had heart attacks their drugs to prevent their second heart attack at no cost to them. They only took them 50% of the time. So we need to go beyond financial incentives, particularly the carrot, as you described, communication, literacy, transportation, not just drug reductions and co-pays to make this work. They took it more often than when they had to pay for it, but still we have a long way to go.
Well, I appreciate that. And being new to the subcommittee, I appreciate to continue to learn on this, and I appreciate the opportunity to participate. Thank you, Chairman.
Well, thank you, Mr. Reed. We have about a minute left to go vote, so perfect timing on your part. Dr. Fendrick, Dr. Grabowski, Ms. Wilson, Dr. Jacobson, you guys were outstanding. Mr. Levin and I both were chatting here, and you've really helped bring along the debate as we move to make Medicare more efficient, both for taxpayers and for the patients that you see, Dr. Fendrick. So we appreciate your testimony today. Your answers were very good. Look forward to working with you in the future. With that, please be advised that members will have 2 weeks to submit written questions to be answered later in writing. Those questions and answers will be made part of the formal hearing record. With that, the subcommittee stands adjourned. Thank you all.